When you go to the doctor when you're sick, you plan to receive a safe drug for your ailment. Now imagine a world where you go to the doctor and you're given a prescription, but there's no guarantee that it's safe. The drug itself simply has not been required to showcase safety data. Would you still take this drug? This is the reality of pregnant people. It's a bizarre concept that the people who are most vulnerable and require medical care frequently are left out of drug research all the time. 98% of all medications lack safety data for pregnant people. The safety data gap feels unfathomable as today's society is proudly focused on evidence-based practice, where medications without clear safety data would not even have the thought of being used for the public. Instead, the status quo presents a drug default. Oxford Languages Dictionary provides two definitions of default. Commonly, it refers to a pre-selected option adopted by a computer program. Researchers have not leaned away from the research default, causing pregnant people to be underrepresented in studies, creating this drug safety data gap. The word default also describes failure to fulfill an obligation, parallel to the situation how modern medicine fails in their moral obligation to provide evidence-based medicine for pregnant people. The lack of safety data for pregnant people deepens the drug default dilemma. The safety data gap expands from antipsychotic prescriptions to HIV treatment, encompassing almost all medications for pregnant people. Miranda Friger's theory of epistemic injustice is the chosen lens to perceive the root of this problem. After defining the issue in terms of a reality and theological base, we will address the movements taken for solvency, emphasizing on rights protection through legality. The story of Dr. Daksha Emson ends in tragedy due to the drug data gap. The 34-year-old esteemed clinician stabbed herself and her 3-month-old baby Freya the day before she was supposed to resume medication for her bipolar disorder. Dr. Daksha was diagnosed with bipolar disorder at age 18, and her husband notes that she didn't have a relapse 8 years prior to this incident. So it begs the question, why did this tragedy happen, and could it have been prevented? Prior to the pregnancy, Dr. Daksha and her psychiatrist decided to stop her antipsychotic medication in order to give birth to her baby Freya and breastfeed her. The drug data gap included her medication, lithium. Dr. Daksha took the chance with her health and was taking off the medication in efforts to not harm Freya. 23 years later, and this gap has not changed as lithium still lacks adequate safety information. A patient and their provider worked together to create the plan of care, just as Dr. Daksha and her psychiatrist did. However, healthcare professionals lack the safety data to make grounded choices for pregnant patients, needing to rely on intuition instead. When prescribing medication, healthcare professionals have 3 choices. First, not prescribing necessary medication. Second, prescribing drugs that are less effective, or prescribing medication that have greater side effects. Medications used routinely lack information on effective dosages and can lead to limiting counseling for patients. Having such safety data would greatly aid the patient and provider's plan of care and communication. Current medications extrapolate safety data from the general public onto pregnant women, so drug specifics on dosage or what trimesters to use the drug are unknown. This action of extrapolating the data aids to how this topic is unrepresented. The public doesn't question once FDA approval is given to medication, allowing a bliss of ignorance. In general, there is more male medical data than female, and within discussion of this disparity, pregnant people are still left out, adding to the underrepresentation. The drug data gap continues to expand from the patient-provider setting into a global public health sense. A study done in 2019 presents the culture of human immunodeficiency virus research in relation to pregnant women. It found that women receiving dolutegravir around conception or first trimester had a substantial risk of 0.9% in their infant developing neural tube defects, as compared to the 0.1% risk for other antiretrovirals. Dantauver and Capistat were another antiviral for HIV that actually caused the opposite of its intended effect. It was found to increase the risk of HIV transmission to the neonate. It took 6 years for safety data to become official, and in the meantime, pregnant women were exposed to these drugs. Similar to psychotropic drugs, healthcare professionals conduct the balancing act with HIV drug administration, hastily evaluating the risk of whether or not to prescribe a prescription based on limited clinical data. This balancing act takes a step towards groups of power such as the World Health Organization. In 2017, the WHO promoted the use of pre-exposure prophylaxis to prevent HIV, targeting those who are pregnant and breastfeeding. But even within their promotion, the studies cited for drug safety had no pregnant people in the trials. WHO presents if that a person did become pregnant within the study, they would have to be removed from it. 5 years later, a study done in The Lancet opposed the use of PrEP due to the severe lack of clinical data. It's possible that the reality of dolutegravir, drunavir, Covistat could become the same for PrEP. No medical professional or organization should have to make a choice regarding treatment without clinically based evidence. A theory of knowledge helps us understand why the drug default gap came to begin with. Dr. Miranda Fricker's theory of epistemic injustice prompts thoughts about distributive unfairness in respect of epistemic goods such as data. The purpose is then to bring knowledge to light and make sense of our own social experiences. The connection between knowledge and social power is emphasized by Fricker, pointing to how social disadvantage produces epistemic injustice. Miranda Fricker's theory breaks down into two categories, testimonial injustice and hermeneutical injustice. Of the two, the second subtheory most closely relates to the topic. Hermeneutics is a theory and practice of interpretation, where interpretation involves an understanding that can be justified. Hermeneutical injustice occurs when a gap in collective interpretive resources puts someone at an unfair disadvantage and negates making sense of their social experiences. The cause of the second sub-theory is structural prejudice and the economy of collective hermeneutical resources. Power is essential to undertaking hermeneutical injustice as it refers to the control one has to understand and the ability to utilize past experience to present situations. Pregnant patients are the powerless as they are unable to make sense of the fact that they are being excluded from research, nor are they given the opportunity to rationalize this social experience. There is no simple term to describe what is happening to pregnant patients as the situation is not straightforward, adding to the underrepresentation. The theory of epistemic injustice allows for the problem of the pregnancy data gap to be understood in terms of knowledge and power. The two hold a relationship that allows marginalization of pregnant people. Not allowing them to take equal participation in the acquisition of knowledge directly affects power within the social structure. The effects of this marginalization is due to the identity power and material power, two more terms from Fricker's theory. Material power refers to the impact that socioeconomics has on hermeneutics, such as jobs. The issue of legality presented by having pregnant patients halts participation, contributing to the power of material. The identity power effect originates from the prejudice-based stereotypes from the social atmosphere, enabling a power imbalance. The identity power takes effect from the societal image that people have on those that are pregnant. The fetus cannot risk any harm, so something like research participation should be immediately rejected. In turn, this leads to pregnant people being powerless and unable to make sense of their realities as treatment comes from extrapolated data, something that will not fit them. The theory of hermeneutical injustice supports the case of pregnant people as the injustice occurs from a structural issue, but note that there is no real culprit. The government agencies, researchers, and the medical field themselves are not the culprit. Due to the power dynamic between them and pregnant people, the lack of knowledge does not cause repercussions to be felt by them. With the HIV case, the WHO cannot be the main culprit in promoting PrEP. Instead, the WHO understands only from the background it has, a lack of data showing that the structure of knowledge creates a circle and is able to put a disadvantage on the actor who is originally deemed with power. This is the genius of Fricker's epistemic injustice theory. The power of knowledge is able to disadvantage both parties but in different ways. The WHO rests on a cultural facade and gives incorrect credibility while pregnant people may feel the repercussions of those effects. In this scenario, the WHO can be replaced with others involved in the research gap, simply anyone with more power than the pregnant people. The virtue of hermeneutical theory is to be corrective towards knowledge and power. This shows the goal for solvency. The theory demands for corrective justice and calls for legal reform and a reflexive awareness theme. In other words, this calls for the actor to be aware of his social identity and the victims, as it can impact the communication and the legal actions taken. The identity of pregnant people must be taken into account when putting forth legal reform to enable success. If the problem is a lack of data, it would appear the simple solution is to gather more. However, the cause of the gap links back to the circulation of knowledge, adding in a theme of power. The three sources that contribute to the drug gap are study design, legality, and government agencies such as the Food and Drug Administration. Beginning in 1993, the FDA started to allow pregnant people into clinical trials. Pregnant people were explicitly excluded prior to 1993, and it's very likely that the ramifications of those guidelines contribute to the structure of research design today. Oftentimes, studies don't include pregnant people due to the fears of legal issues and wanting to avoid harm towards the fetus. This thinking then contributes to current studies that do clinical trials to use mostly animal models. However, companies often give pregnant animals a dose that's much higher than what would be used on humans, causing the same idea of extrapolation onto pregnant people once again. For this topic, it is clear that much of the literature calls for legal reform. This can look like rights protection for researchers who fear having pregnant participants, and also governmental policies advocating for the rights of pregnant people, specifically that they must be included in earlier trials of clinical testing in order to have adequate data. Current reform has been slow, but most notably started in 1962 when Congress passed the Kefauver-Harris amendments due to the thalidomide scandals, giving FDA authority to ensure drug effectiveness and reporting on adverse effects from manufacturers. The thalidomide scandal concerned pregnant people, as the case goes of how the drug was approved for pregnant people for their morning sickness but never tested on them. 5 years later, it was found that the fetuses were affected by the drug and would develop deformed limbs and defective organs. An estimated 10,000 fetuses were affected by thalidomide, and about half of them died within the first few months. Many countries urgently created new laws and policies in wake of the thalidomide scare, as they acknowledge how important evidence-based practice is and how research is needed to provide safety for the general public. Yet, even when the case of pregnant people has led to drug safety for the public, they are the very ones most neglected. Through the years, the FDA has published guidelines for manufacturers and researchers regarding drug safety. In 2016, new guidelines were placed to create actual captions of information versus a lay ABCDX range. But medications still have yet to fully display all the information suggested by the FDA. Epistemic injustice virtue's ultimate end is aimed at understanding. Thus, hermeneutical justice would occur when there's no longer a drug safety data gap based on the marginalization of pregnant people. Ending the drug default would support the patient's right to health. Justice would be to enact the governmental agencies and the medical field itself to make solid evidence-based decisions. That way, tragedies like Dr. Daksha Emson do not need to persist.